as you know, hip involvement is seen in almost 15 to 20% of osteoarticular tuberculosis. And in India, we have almost 25% of all childhood TB cases worldwide, and almost second highest incidence of multi-drug resistant tuberculosis. So it is really a great burden for India. The goal of treatment in tuberculosis of hip is not just healing of the disease, but we want to have a functional, painless, mobile, and stable hip at the end of the treatment, and thereby prevent secondary osteoarthritis. Unfortunately, in majority of the conditions, we don't get this and we have an unfavorable outcome because majority of the cases are presented late to us, or there is delay in diagnosis, or there is inadequate treatment, or there are defaulters. And hence complications and sequelae of TB hip in children is a major problem in India. As you can see this case of hip synovitis was being treated as Perthes disease, and it was too late by the time it was diagnosed as Cox, and child ultimately landed up with a fibrous ankylosis. So the goal and the management, if you want to get the best function, the first goal and the first step is to have early diagnosis. So clinically, we all know that tuberculosis of hip passes through these stages of synovitis, early arthritis, advanced arthritis, and advanced arthritis with subluxation and dislocation. Each stage has typical clinical findings of the hip. But as we all know, these findings are very common with other common conditions of pediatric hip like transient synovitis, Perthes disease, juvenile rheumatoid arthritis, and so on. So to get a clinical perfect diagnosis of Cox is not that easy. Also, the radiological features are also not specific. We see rarefaction, osteopenia, some cystic changes. And in fact, Shanmukh Sundaram has classified these various radiological types of tuberculosis of hip, where it can behave just as benign as a normal looking hip to something like traveling acetabulum, dislocating hip, Perthes type of Cox, pseudoacetabulum, protrusio-acetabulum, atrophic type, and there are more to it, and some new unclassified varieties are also seen. Moon from Korea has modified this classification just to find out and explain more about the stability of the hip and the cephalocotyloid relationship in these different varieties. But they don't help much in your diagnosis and treatment, except that they give us some prognostic value where the normal type and the triradiate type have good prognosis, whereas the atrophic type or the ankylosing type has poor prognosis. So radiology and clinical features are not enough to diagnose a case of Cox hip. And we need MRI for these cases for diagnosis, which is quite sensitive, but again, not very specific. The serological tests like ESR and all are quite non-specific. So what we need is the proper microbiological diagnosis, and this can be done with a synovial fluid analysis by aspiration and a synovial biopsy. We have now liquid culture media like Bactec MGIT, where we can get the growth within as less as 1 to 3 weeks, and we can also get the drug sensitivity report within 7 to 10 days. So these should be done in any suspected case of Cox hip. And there are certain newer molecular tests which can also diagnose the multi-drug resistant tuberculosis right at the start. So we can start on the respective specific chemotherapy for the best outcome. So there are this gene expert MTB rifampicin assay, which can guide us about the rifampicin resistance as early as within 2 hours. And there are this line probe assay, which can tell us about rifampicin or isoniazide resistance. So now once the diagnosis is made, the next step is how we manage the cases in a timely manner and get the desired good outcome. So mainly tuberculosis of hip, we require a thorough medical management, especially if it's a synovial variety and in the early stage. A proper anti-Cox treatment as per the revised National Tuberculosis Control Program guidelines is what we need to start off at the diagnosis of Cox hip. The correct choice of drug, the correct dose and duration are very important to have the proper effect and a good outcome. We should also have serial monitoring for the response and look for any adverse reactions. Some analgesics may be supplemented and some general nutritional measurements for the symptomatic relief. There is controversy regarding immobilization, whether to be done or not. Before that, let me just tell you about the dose and the line of AKT which we use. So first line of AKT, these drugs are used as per our RNTCP guidelines. The intensive phase lasts for about 2 months, whereas the continuation phase goes on up to 10 to 16 months. If it is a MDR TB, if we have diagnosed, then we have to use the second line of treatment, where the intensive phase is about 6 to 9 months and the continuation phase goes on for about 1.5 years. And if it's an XDR TB, then the initial phase is as prolonged as 12 months and then continue with 18 months of proper AKT. So as I was talking to you about the immobilization, there is a controversy whether we should immobilize the hip joint or allow it to be mobile. So use of traction is recommended for the initial 4 to 6 weeks because that helps in relieving the muscle spasm. It maintains the joint space, which is very, very important because it's been seen that poor outcome is seen if the joint space is reduced to less than 3 millimeter. And the traction method can prevent and correct deformities and subluxation. But unlike it was implemented earlier for prolonged immobilization, now we have to, the concept is that you should have mobility with stability. So as soon as the patient is pain-free, you must start with active and active-assisted exercise and start with early weight bearing whenever the patient can tolerate pain. And this mobility will help in fact, regenerating the cartilage and get the good functional outcome. So what is the role of surgery in case of tuberculosis of hip? So synovectomy and debridement is required in case there is failure to respond to anti-cox treatment for the initial 4 to 6 weeks when you start and you don't find the required response. And there are some specific surgeries which are done in advanced cases with dislocation or deformity. The principles what you should follow for synovectomy and debridement is that you don't have to go and do a total synovectomy. You just require to decompress the joint. You must preserve even partially loosened cartilage as there is great potential for regeneration and remodeling, unlike in a septic arthritis. And you should see to it that you avoid any extra injury to blood vessels and don't add avascularity to this already compromised hip joint. So disadvantage of this conventional arthrotomy is that there is risk of increasing morbidity and worsening conditions due to intra-articular adhesions. And if you cause vascular damage, then it's a major brunt. So nowadays at some centers, there is arthroscopic debridement done, which is less invasive and safe. It's a daycare surgery with early return to activity. And this is an emerging modality which provides rapid and significant relief to patients. And it can also help to confirm the diagnosis by providing tissue sample for histopathology and culture. So there's a nice paper from India, from Delhi, published in JCO, where they have done this procedure, arthroscopic drainage for active pediatric hip tuberculosis done in 22 patients. And they've in fact done a grading of the tuberculosis hip, where grade 1 is just showing inflammatory changes, whereas grade 3, there is total destruction of hip with no visible integrity of internal structures. And this grading has a prognostic significance, and they said that the labral damage is the worst functional outcome. There are in fact very few articles, if you go through literature, on tuberculosis of hip, and some of the prominent ones by Moon from Korea and from India. The consensus, if you go to see the stage-wise treatment for tuberculosis of hip, is that in synovitis stage, you start with the proper AKT, 2 months of intensive phase, and then 10 to 16 months of continuation phase. You give traction for initial 4 to 6 weeks, and as I said earlier, start with active assisted exercise once pain is relieved. In addition to this, in early arthritis stage, if the response to AKT is not good, then you should go ahead with synovectomy and joint debridement. In advanced arthritis, this debridement may be required in most of the cases. And advanced arthritis with subluxation or dislocations are really complex and difficult problems. There is no simple solution, and you have to judge and make the decision as per case. For example, if there is traveling acetabulum, you may do a varus osteotomy to contain the hip. In case of dislocating hip, you may have fluid reduction procedure and so on and so forth. But you have a very poor prognosis if you present and you diagnose the case at this stage. So if I have to conclude, TB hip in children continues to be a major problem in India. Early diagnosis by appropriate tests is the key for getting a good outcome. You must diagnose at the outset MDR or XDR TB cases so that the respective chemotherapy can be started right at the outset. And appropriate AKT and judicious use of surgery is the key to obtain best functional outcome. Thank you so much.